The following podcast is part of a certified educational activity titled Collaborating with Peers to Optimize Obesity Management in Women. Clinical Considerations Before, During, and After Pregnancy. Access the entire activity and complete the post-test at peerview.com/SPP860. Downloadable slides and practice aids are also available.
My name is Courtney Younglove. I'm a physician dual board certified in obesity medicine and obstetrics and gynecology, and I've been practicing clinical medicine for over 25 years. I'm also the founder and medical director of Heartland Weight Loss, an obesity medicine practice in Overland Park, Kansas. Welcome to Collaborating with Peers to Optimize Obesity Management in Women, Clinical Considerations Before, During, and After Pregnancy. First, we're going to spend some time reviewing how obesity affects women. Then we'll discuss the principles of obesity management in women before, during, and after pregnancy. This is a very big topic to cover, and we certainly can't do it all in the span of an hour. Our goals for today are to augment your knowledge about the benefits of obesity treatment in women of childbearing age and why guidelines support early treatment of obesity as a serious, progressive, chronic disease. To provide you with a framework to effectively counsel women of childbearing age about the benefits and limitations of current obesity treatment options, and to equip you with strategies to individualize weight loss goals pre and post pregnancy. So let's start with understanding the intersection of obesity and women's health. Why is this topic relevant? In the United States today, over 42% of our adult population lives with obesity. Another 30% lives with pre-obesity or overweight. It affects more women than men, especially severe obesity, and rates also follow the socioeconomic gradient. Aside from the overall prevalence, obesity also has more detrimental effects for women than men. Studies show that women living with obesity experience more weight bias and stigma than men do. This isn't terribly surprising in a society where a woman's value is strongly tied to her appearance, but it deserves to be said out loud. And although people of both sexes tend to gain weight with age, women are more likely to experience periods of abrupt, sometimes dramatic increases in total body weight, which can be emotionally and physically very disruptive. When obesity affects women during our childbearing years, the population we are focusing on today, it can have profound detrimental impacts on fertility itself, on pregnancy outcomes, as well as a woman's long-term health trajectory. It is even associated with worsening outcomes in future generations. There isn't much in the human body that isn't affected by obesity. Take a minute and look at this slide. The organ systems that we share with men are almost all affected. However, women carry a greater burden of risk with our reproductive organ system than men do. Although men with obesity have higher rates of prostate cancer, women with obesity have higher rates of multiple types of cancers, as well as reproductive functional issues. Chronic pelvic pain, abnormal uterine bleeding, polycystic ovarian syndrome, urinary incontinence. These are things you likely deal with every single day. They are all common conditions, and they are more common in women with obesity. And having obesity makes the physical examination more difficult, resulting in an increased incidence of imaging, procedures, and cost. This problem isn't going away. Obesity is common, and the incidence is worsening year after year in women of all ethnicities and all ages. Obesity affects maternal and fetal health in a number of ways, from issues surrounding ovulation and conception to pregnancy success and complications to pregnancy outcomes. We are going to talk a bit more about these in a bit, but we need to recognize that obesity in reproductive age women has profound impacts on current and future generations. Addressing it and treating it individually and from a population health perspective is vital. Obesity is a common cause of anovulation and oligoovulation. It's associated with an increased risk of pregnancy loss, pregnancy complications, delivery complications, and poor neonatal outcomes, including congenital abnormalities and growth abnormalities. Just as preventing and treating obesity in the general population will reduce rates of chronic disease, preventing and treating obesity prior to pregnancy can significantly reduce the risks associated with pregnancy. Everyone who works in women's health is aware that adverse pregnancy outcomes are not uncommon. But seeing the risk correlation with maternal body mass index should make us all pause. Every 10% difference in pre-pregnancy BMI is associated with clinically meaningful risk increases for preeclampsia and gestational diabetes. And the data for cesarean section is equally impressive. The only pregnancy complications that don't seem to be associated with obesity are postpartum hemorrhage, which makes sense if you look at the pathophysiology, and mortality, severe morbidity, as these are often due to catastrophic events like amniotic fluid emboli or homicide. The incidence of these are less common than the complications on the last page, so the y-axis is quite a bit different, but there is also a correlation with obesity and these issues, especially macrosomia and indicated preterm birth. Spontaneous preterm birth is fairly agnostic in terms of relationship to maternal weight and BMI, though, but overall preterm birth is definitely more common in women with excess weight. Gestational diabetes gets an entire slide to itself because it's just that meaningful. Maternal obesity carries an increased risk of gestational diabetes, which is associated with an increased risk of poor outcomes and an increased risk of long-term sequelae for both the woman and her offspring. This is likely driven by the intrauterine environment, the elevated glucose levels, elevated insulin levels, and elevated lipid levels that are associated with impaired glucose regulation. We don't know that the actual experience of having gestational diabetes is what increases a woman's risk of future cardiometabolic diseases. It's likely that pregnancy acts as sort of a stress test, that the experience of being pregnant stresses the woman's system and gives us a unique glimpse into what her long-term health trajectory really looks like. But we honestly don't know. The Obesity Medicine Association, or the OMA, is our governing body in this field and functions similar to the way that ACOG functions for OBGYN professionals. Every year, members of the OMA come together to assess and evaluate the new data that's been released and synthesize anything relevant into the next year's obesity algorithm. The algorithm is a massive document available to members and serves as kind of an obesity Bible. This definition has evolved over the years, and although it's really wordy, I think it does a great job of representing the complexity of this disease. I'm going to read it because hearing it is often more powerful than just reading it internally. Obesity is defined as a chronic, progressive, relapsing, and treatable, multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. And hopefully you aren't in the mindset that obesity is a disease of sloth and gluttony, or the inability or unwillingness to balance energy intake and expenditure. But in case there's still a kernel of that lurking in the back of your mind, it's helpful to see all of the things beyond counting ability and motivation that contribute to this disease. It is complex, to say the least. So why does this matter? Because we know that when we as clinicians approach a topic, our patients take it more seriously. Although most people with excess weight want to lose it, they're much more likely to make a meaningful attempt to do so if a trusted clinician recommends that they do it. When we ignore it, patients are more likely to ignore it too, or to think about it as a personal responsibility problem to tackle someday. When we discuss it similar to the way that we discuss other chronic diseases, and we do it well, we give credibility to their concerns and their struggles. Unfortunately, patients with obesity often have scars from previous discussions about their weight. Bias and stigma is the norm when it comes to the way that we, individually and collectively, view obesity. And although some of this bias is internal, a lot is external. If you look around, you can see it everywhere, and the halls of medicine are no exception. Healthcare bias is real, even today, and it can have devastating consequences for patients experiencing it, including avoidance of future care and diminished adherence to treatment. Bias in healthcare can be overt, making derogatory comments about someone's weight or offhand remarks about needing to get the big girl cuff, or the big girl speculum, or the bigger gown. It's also in making judgmental statements like, you should just eat less, or if you ate less, you wouldn't have diabetes. Comments like these are incredibly common and perpetuate the idea that someone has excess weight because they are lazy or stupid or unmotivated. Bias in healthcare also comes in workup and treatment. People with obesity are less likely to receive a workup when they present with a complaint. Clinicians often attribute the complaint to excess weight instead of going through a differential. Conversations about treatment often focuses on weight loss as the solution, ignoring other treatment options. People with obesity are less likely to get imaging and more likely to get a lecture. This is healthcare bias. And when you experience bias, it makes sense that you are less likely to seek out care again, later, even for a different problem. So, one of the things we talk about also is there are a lot of ways in which bias and stigma presents in the medical exam space that people don't even realize it's happening. A lot of times, the furniture in exam rooms or the furniture in waiting rooms is not built for patients with obesity. So, sitting in the waiting room, feeling like they're going to topple a chair or sitting on a table that is too narrow for them makes them immediately uncomfortable and puts up barriers to care. A lot of times, our exam gowns in gynecology are not big enough to cover a woman's front section when she puts it on. So she has to have the initial discussion with her provider with her breasts hanging open, again, feeling incredibly vulnerable and uncomfortable, which puts up barriers. We often have blood pressure cuffs that aren't big enough. And often our staff will try a blood pressure and be unable to achieve it with a normal blood pressure cuff and then make comments as they have to go get the bigger one. And patients don't want to hear about having to go get the bigger thing to take care of them. Same thing with the speculum. Same thing with all of the things we use in the exam room is it really can affect our patients and the perception of our preparedness and our expectations for them. The reading materials in our exam rooms, in our waiting rooms, can also subtly promote bias and stigma. If we have these fancy women's health magazines that show skinny people on the covers and tips about dieting and cosmetic associations with weight management, it sets the stage that we view our patients with obesity as needing to deal with those issues outside of our exam room. So, really being cognizant of what's around us, what our patients hear and say and see and hear us say is very, very important. Another one is having the scale out in the middle of the hallway where they have to step on that scale as people walk by. That can be incredibly distracting. It can be very humiliating for people. So, moving the scale into an alcove or into a space where patients can be weighed in private is important. And patients sometimes don't want to be weighed. So, respecting that decision, as long as it doesn't need to be done to absolutely do something in the care plan, should be done, or allowing them to turn around and not see their weight. These are all things we can do that are small but really impactful within our medical clinics that can help patients with obesity feel much more comfortable seeking care from us and adhering to treatment and coming back. So, we need to discuss weight, but we need to do it well. So, what does that look like? Patients don't necessarily object to the discussion, but asking them if they know that they should lose weight or being flippant or offering unhelpful advice like eat less or eat better is not appropriate either. When I was practicing gynecology, I found that many of my patients brought it up, so I didn't have to. But those that didn't, I usually asked, "Are you concerned about your weight?" Or, "I noticed that you've gained weight since last year's visit. Do you want to talk about it?" It really wasn't hard, and most people really did want to talk about it. It's also really, really important to use patient first language when discussing weight, verbally and in our charting. Obesity is a disease, not a descriptor. She has obesity, just like she has cancer. We don't say she is a 51-year-old cancerous patient. We shouldn't say she is a 51-year-old obese patient. Words matter, and the wrong words can shut down a conversation forever. Most of the time in medicine, we avoid asking questions or talking about things that we don't know how to treat, which is why learning about treatment is so important. Until a few years ago, most of my peers in obstetrics and gynecology didn't want to talk about obesity treatment. Many referred patients when the patients brought the subject up, but I don't think many initiated conversations about treatment. This is starting to change. Surely you have patients asking you about these new anti obesity medications. Whether you like it or not, As women's health clinicians, you often serve as the patient's primary or only touchpoint to the healthcare system. But just like other complex chronic diseases, you likely don't have the time or the bandwidth to manage obesity, which is valid. But ignoring it altogether or trying to do it all aren't the only options. Similar to the way we deal with most non gynecologic chronic diseases like hypertension or diabetes, it's helpful to have a base understanding of the disease, the treatment options, and a place to refer patients that you feel comfortable with. So let's start with defining the problem. What is obesity? Obesity is the presence of excess adiposity or excess fat mass. We have traditionally defined obesity and pre-obesity by BMI, although we are finally starting to make headway getting away from that simple classification. Body mass index or BMI only calculates weight, which is a limitation. There are a handful of people in this world who have excess weight, but it exists in the form of muscle, who are erroneously classified as having obesity when using the BMI classification system. Very few clinicians would diagnose a bodybuilder like this with lots of muscle as having obesity, so let's put those people away for now. What happens more often, though, is that BMI misses people with excess adiposity, people who have a normal or slightly high total body weight, but they are undermuscled, which especially happens in women, especially as we age. This is why we are getting away from just using the BMI classification. You don't have to dive deep into this concept, but just know that obesity is defined as having a body mass index of 30 or higher, or having an enlarged waist circumference. For women, this is more than 35 inches, because it's a reflection of having excess visceral fat. Or it's defined by having a total body fat percentage higher than normal, for women more than 35%. Pre-obesity or overweight is classified as a BMI between 25 and 29.9, or a body fat percentage between 30 and 35%. We don't have a waist circumference measurement defined for this yet, but we probably will in the future. Now, there are some ethnic specific variations as well, which we aren't going to get into, but the big takeaway here is that obesity is excess body fat, which isn't always obvious from simply looking at a person or looking at a number on a scale. So many people have this idea that if they don't achieve a normal weight, then what's the point of trying? One of the things we used to say to each other in the operating room is the enemy of good is better. And I think it applies here as well. It does not take normalization of weight or adiposity to have a positive impact on overall health. Even a small amount of weight loss is typically incredibly beneficial for people living with obesity in terms of long-term risks, disease improvement, and overall quality of life. In fact, we use the term clinically significant weight loss to describe anything more than 5% of total body weight loss. In most cases, the greater the weight loss, the greater the health improvement, but that's not a hard and fast rule, and it's not applicable to every individual. And creating the expectation that this needs to happen is a recipe for disappointment and discontinuation of therapy. So, this is a great visual for taking a wide angle view of obesity treatment. Like other chronic diseases, treating obesity should never be approached with a one size fits all strategy. There are multiple types of treatment that are meant to be layered on top of each other. The more severe the disease state, the more we need to climb up the pyramid, but not at the expense of ignoring the bottom blocks. So let's start at the bottom, the foundation of treatment. This goes by several names: an intensive behavioral intervention, an intensive lifestyle intervention, or just a lifestyle intervention. It's way beyond eat less and move more, and it's definitely beyond giving someone a handout with some ideas about how to do that. It involves working with the drivers of behavior and habits and re engineering the way we approach and execute our health promoting behaviors. Now, there are always special snowflakes that are able to lose a significant amount of weight using lifestyle interventions alone, which is great. Most people are not successful, though, for a number of reasons. We don't ignore this step, though, as having this tool in the toolbox is absolutely essential for long term success when moving up the pyramid. It's also important to point out that healthy behavior, healthy eating, and regular exercise, and good sleep and stress management, etc., are all great, but they aren't necessarily the same thing as weight loss behaviors. Preventing a disease and treating a disease are two very, very different things. We understand this when it comes to cancer. and pregnancy and STDs. Health promoting behaviors should be a part of treatment of these conditions, but they rarely cause absolute disease remission or a cure. By the time a disease has taken root, we typically need more aggressive treatment to improve it or even reverse it. Let's move up the ladder of treatment intensity a bit. Here is the definition of a prescriptive nutritional intervention. It's defined as purposefully planned actions intended to positively change a nutrition related behavior, environmental condition, or aspect of health status for an individual, target group, or the community at large. This can be incredibly prescriptive, like a medically tailored meal plan with or without meal replacements, or can be something more vague but still focused, like a ketogenic diet or a low carbohydrate, high fat diet. It's definitely more than eat less or eat less calories or everything in moderation, though. The next level of treatment intensity is pharmacotherapy. We will touch upon this a bit more later, and we certainly don't have time to dive into the nuances of all of these, those that are FDA approved for short term use versus long term use, the indications, contraindications, side effects, etc. What I want you to take away from the slide is that these rest upon the other pillars. Pharmacotherapy does not exist in isolation and is only approved and studied in populations with obesity and pre obesity with comorbidities or complications. Now, endoscopic procedures such as the intragastric balloon and the endoscopic sleeve gastroplasty aren't used much outside of studies and academia, but it's important to acknowledge that they exist, and again, when used, should always be layered on top of other strategies. Metabolic and bariatric surgical procedures have a significant role to play in treating the disease of obesity. In fact, metabolic and bariatric surgery is the gold standard for treating patients with grade 3 obesity. Again, these interventions are designed to be layered on top of other therapies and reserved for patients with more significant disease. There's a lot of information on this slide. We have three separate populations: women before, during, and after pregnancy. And we are talking about the various levels of treatment. So bear with me. We're going to start at the bottom, thinking about treatment similar to the stepwise pyramid we just reviewed. First, an intensive behavioral intervention. Which of these populations are candidates for this? All of them. Creating foundational systems and habits around nutrition, movement, sleep, stress management will benefit women in all stages of life. The sooner the better, as obesity is a chronic, progressive disease. Second, a prescriptive nutritional intervention. Again, all three populations could benefit. There are some nuances here. Although a prescriptive nutritional intervention should optimize to prevent any micronutrient or macronutrient deficiencies, these are a bit more nuanced than someone who may become pregnant soon. During pregnancy, instead of weight loss being the primary goal, this intervention would need to be optimized for appropriate weight gain, and post pregnancy would need to be optimized to support lactation. Let's move up. Pharmacotherapy. So, pre pregnancy, there are a few options. We will dive into those here pretty soon. Anti obesity pharmacotherapy is never indicated during pregnancy or lactation, at least at this point, for lactation, nor are any endoscopic or bariatric or surgical procedures. Now, these can be done pre pregnancy, but each has a specific post procedure window during which pregnancy is contraindicated for various reasons. We will talk in a bit about how weight loss is never recommended during pregnancy, so getting pregnant following a procedure that causes significant weight loss is a bad idea overall until weight has stabilized. There's a lot on this slide to digest as well. The interventions we use to treat obesity have varying levels of effectiveness. I want to point out that when we talk about the effectiveness of each of these various interventions, we are talking about the average response. For every therapy, there's a wide range of responses, including non-responders and hyperresponders. This is true in all disease treatments, but it often gets lost when talking about obesity treatment. We hear a lot about the hyperresponders, and often we assume that everyone is going to respond similarly, and that we or they have failed if it doesn't happen, which can contribute to stigma and bias. It's also important to point out that these data are from clinical trials, which are usually radically different from real world experience. And the lifestyle intervention trials are all over the place in terms of how they were executed. Another thing to keep in mind is that most of these studies are encompassing active treatment for around a year or more. The older the medication or intervention, the shorter the treatment arm was, which is a limitation, as is our lack of long term data beyond study duration. The medications that are only FDA approved for short term use don't even get to be included here, but it's important to realize that when they were brought to market years ago, we didn't think about obesity as a disease, and they were only required to study participants for 3 months. So that's what they did. It's really hard to compare apples to apples when it comes to anti obesity pharmacotherapy. But looking at the slide, at the average response to treatment, you can see that lifestyle interventions have the lowest average effectiveness, followed by the older generation anti obesity medications, followed by the newer agents, followed by metabolic and bariatric surgical procedures. And with the more powerful interventions, we have a much wider range of average weight loss. Many people aren't familiar with the older anti obesity medications, so let me briefly review them. Okay, so let's talk for a few minutes about the different medications listed on this slide. So, orlistat is a gastrointestinal lipase inhibitor, which means it prevents the absorption of some of the fat that we ingest. Because fat is absorbed in the small bowel, if we don't absorb that, that fat stays in the stool, stays in the colon, and comes out the other end. So, not surprisingly, adverse effects from this medication are diarrhea, oily stools, fecal incontinence, and some fat soluble vitamin deficiencies. Because these side effects can be incredibly disruptive, this medication isn't actually used very much at all, which is completely understandable. Naltrexone bupropion is another old medication that has been on the market for some time and is a combination of two generic medications that have been around and been very well studied for a long time. These are also in a slow release tablet in lower doses than most people are used to using, which is incredibly beneficial for patients that have side effects from them. Naltrexone is an opioid receptor agonist, so it blocks the opioid receptors. So patients taking opioid medication shouldn't take this. Bupropion lowers the seizure threshold in patients with seizure disorder. So bupropion is not to be used in patients with seizure disorder. So there are quite a few contraindications there, but it is a select population. And it's very well tolerated in most people. Naltrexone can cause some nausea, but in such a low dose over a slow release tablet really minimizes this. And a few people can get some hyperstimulation from bupropion, but it is fairly minimal and is very well tolerated by patients. Phentermine topiramate extended release is a medication that's been on the market for some time. It's a combination of two previous old medications, phentermine, which is FDA approved for short-term weight loss, although it is used long-term in many, many cases, and topiramate that has been on the market for treatment of migraines. The combination of these medications is very synergistic, amplifying the effect of phentermine, and is also brought into a slow-release tablet, which allows lower dosing of both medications and improved tolerability. Phentermine itself is a sympathomimetic amine. It is similar to Ritalin or Adderall and can cause a little bit of increase in heart rate and blood pressure. It is very, very benign overall. I think the overall heart rate increase is 2 to 3 beats per minute, and the blood pressure is 2 to 3 millimeters mercury systolic. So, nothing terribly dramatic or scary, but it is contraindicated in people that have severe uncontrolled hypertension, a history of thromboembolism, a history of myocardial infarction, etc. And it's contraindicated in people who are already taking any other type of stimulant medication, as we don't want to combine those effects. Topiramate is a fairly safe medication, although it has decent side effects. Some mental fogginess, um, fatigue, and ironically, it can make things taste funny, which is probably one of its mechanisms of action in treating obesity. Um, Again, this combination of medications in a slow release, extended release tablet allows us to use very low doses of these medications and dose it once a day, which is pretty important and very helpful for patients that are struggling with excess weight. Now, who can't use these medications? Anybody, again, who might become pregnant, since topiramate is teratogenic. We don't use it in nursing. Again, we don't use it in anybody with a history of cardiovascular disease like stroke or arrhythmia. Anybody who already is in a hyperstimulated type environment, like they already have uncontrolled hyperthyroidism or agitated states. but it is used very well and it's tolerated very well. Side effects are consistent with the two medications that it contains. Biggest side effect of phentermine is constipation, dry mouth, and trouble sleeping. Side effects of topiramate is mental fogginess and fatigue. Liraglutide, semaglutide, and tirzepatide are the newer generation anti-obesity medications and are classified in general as GLP-1 receptor agonists. Tirzepatide is actually a dual agonist affecting GLP-1 and GIP receptors, although it often gets classified as a GLP-1 drug just to make it easier. Liraglutide is the first injectable GLP-1 agonist that was brought to market for treatment of obesity. It is a daily injection, and its effectiveness is a little bit lower than the next generation medications, the two next to it, semaglutide and tirzepatide. It is not used as much anymore with these newer generations on the market, namely because it does require a daily injection and the efficacy is a little bit lower than the other two medications. All of the GLP-1 medications work in multiple ways. They delay gastric emptying, they increase glucose-dependent secretion of insulin, they suppress glucagon secretion, stimulate glucose uptake into cells, lower hepatic glucose output, and promote beta cell proliferation. They're actually amazing drugs in terms of how they work. They are also more appropriate for more people. There are much less contraindications to these medications than our older medications. The only real contraindication right now that we know of is people with a history or a family history of multiple endocrine neoplasia type 2 and or thyroid medullary carcinoma. We are we are very cautious with these medications in patients with a history of pancreatitis uh, and or gastroparesis, as side effects of these medications can be those conditions. So we certainly don't want to set someone up to get recurrent problems or amplify something that is already in existence, but they are not absolute contraindications. Big side effect of these medications are GI. As with most of our anti-obesity medications, they are hitting receptors in the GI tract. So we do see quite a bit of nausea, vomiting, diarrhea, constipation, reflux type symptoms. These medications, like our other anti-obesity medications, are typically titrated up from a very low dose to a dose that is effective for the patient to try to mitigate some of these side effects, but some of them are there. Most people get through it pretty well, but side effects that limit treatment tend to be GI for all of our medications. So, in addition to the medications we just reviewed on the previous slide, it's also important to recognize that there are some anti-obesity medications that are currently FDA approved only for short-term use. This doesn't mean we cannot use them beyond short-term use. It just means when they were brought to market, all the FDA required was a short trial. Back then, obesity wasn't seen as a disease, so treating it over the long haul just wasn't something that people did. Now, we certainly use these medications off label, just like we use medications off label in all fields of medicine. And, and we actually have quite a few studies showing the safety over long term use. The most commonly used medication that you will probably hear about is phentermine. It's been around for a very long time, and it's one of the components of one of the longer acting medications, the topiramate phentermine combination that we talked about earlier. We have plenty of data about using the medication as part of that combination therapy long term, and there are other publications reviewing off label use long term that show a great deal of safety and efficacy over the long haul. So realize in the field of obesity medicine, we are working with the tools that we have, tools that have been rolled out over a long time horizon that have different indications and contraindications, et cetera. But we are working with the tools that we have. The nice thing about these older medications is that they're very inexpensive. Same thing with the medications that are combined into the long acting medications. They are also available as generics and are usually low cost. The the nuances of them can be a little bit difficult, and a lot of times it's it's something that needs to be done by an obesity medicine physician or clinician, but they do exist, and you might see them if someone is treating your patient with obesity in an obesity medicine clinic, or if you want to dive deeper into the treatment options yourself. We are going to hone in a bit on these because they are definitely getting the most attention these days, both from within the halls of medicine as well as from a direct to consumer way. Their average effectiveness is more than the average effectiveness of the older generation medications, at least semaglutide and tirzepatide. They are definitely more effective for more people than the older medications. But one of the things that's important to recognize here is that these therapies were delivered over a very long period of time. Older trials were more short term, and these were much, much longer. Most of us tend to think about weight loss as something that needs to be done quickly and efficiently. But one of the things that these drugs did for the field of medicine is to shift the conversation to talking about obesity treatment, which is different than weight loss, and shift our thinking to appreciate that this is a long game, which is pretty standard for other chronic diseases as well. I could talk about this for hours, and it's not the subject of this talk, but I have to touch upon it because we have all been exposed to a lot of conflicting information about this topic, and it's incredibly relevant right now. High disease prevalence, plus high demand for these peptides, plus exorbitant costs and poor access created a perfect storm a couple of years ago that sparked an entirely new market dubbed the gray market. Many compounding pharmacies, whose role used to be primarily to compound drugs that weren't available or in shortage, or for people who needed special formulations because of an allergy or some other personalized issue, capitalized on a legal loophole that allowed them to mass produce copies of these drugs. And they did, with little to no oversight. These compounded medications are not the same thing as generic formulations because the active pharmaceutical ingredient, the API, is not publicly available like it is for generic medications. It's still under patent. Although clever chemists can likely work backward from the real thing and come up with something very similar, just like Walter White did in Breaking Bad, then they can produce it in a facility that is used to producing compounded medications. The very essence of the drug, the API, is unregulated. The facilities are somewhat regulated, although the oversight isn't nearly as tight as it is for actual pharmaceutical facilities. And if something bad happens, there are a lot of layers of responsible parties, which allows a lot of messiness into the whole space. Because the shortage is technically over, these companies are not supposed to be producing mass copies of these, although it's clearly still happening. And because treating the disease of obesity has historically been seen as something to be done outside of the halls of medicine, as more of a personal responsibility issue, and because of the sheer number of people looking for help with their weight, there are a lot of companies trying to grab profit from the addressable market. We see a ton of this in women's health too, so you are likely very familiar with the concept. But I want to point out here that when studied, the vast majority of these solutions are misleading and or unsafe. They are also poorly regulated, even more so than the compounded medications. And similar to the compounded peptides, be very, very careful putting your name and your license behind these things. Okay, now we're going to dive into some case studies. Jenny. Jenny is a 32-year-old woman, gravida zero, who presents to your office for a problem visit. Her chief complaint is an inability to conceive despite trying for 6 months. Her past medical history is significant for obesity and PCOS. She has been taking a compounded GLP-1 drug that she's been getting from a local med spa for the past few months and has lost a little bit of weight. She is a bit discouraged, both about the weight loss and because she was told that she would likely get pregnant without any issues if she dropped some of her weight and took this medication. Aside from a body mass index of 37.6, her vitals are unremarkable. Now, you are likely very familiar with polycystic ovarian syndrome, or PCOS. PCOS affects a significant proportion of our population. It has a strong correlation with obesity, but at this point, we don't have causality in either direction. We certainly see women without obesity that suffer with PCOS, and not all women with obesity develop PCOS either. We do know that it has a very, very strong correlation with hyperinsulinemia, which makes complete sense as we move further and further away from the calorie balance hypothesis of weight regulation and integrate the actual physiology of energy storage and regulation. PCOS is a very common cause of infertility and subfertility. It's also associated with an increased risk of pregnancy complications and long-term risks of developing multiple chronic diseases, including type 2 diabetes and several mental health disorders. Jenny has already been diagnosed with PCOS, so we don't need to walk through the workup, but we do need to take that information into account as we think through how we are going to counsel and manage her case. Not surprisingly, ACOG has a lot to say about managing PCOS in women living with obesity, but they don't dive into the actual specifics of how to do this, which is understandable given how rapidly this field of medicine is evolving. But let's look at what they say. In the most recent practice bulletin, ACOG rated lifestyle modifications and improving insulin sensitivity as having level A evidence. They also stated that weight loss would improve pregnancy rates as well as glucose tolerance and lipid levels, which is a good thing when a woman is preparing to enter pregnancy. Aside from mentioning orlistat, which again isn't widely used or tolerated, and silbutramine, which was removed from the US market in 2010 due to an increased risk of non fatal myocardial infarction and non fatal stroke with long term use, ACOG doesn't dive into actually how to do this. Acknowledging that treatment is necessary is a good starting point, and I imagine one of the reasons you are here is to start accumulating tools to take it to the next level. Since Jenny is not yet pregnant, let's focus only on the relevant part of the previous graph. Should we recommend an intense behavioral intervention? Yes, because it's the foundation of treatment and can and should be continued throughout pregnancy when she gets there. What about a prescriptive nutritional intervention? Also, yes. Optimized for the fact that she will hopefully be pregnant in the near future and doesn't want to enter pregnancy undernourished or malnourished. Pharmacotherapy is not contraindicated in this patient, although options are limited as she is not only not preventing pregnancy, she is doing everything she can to facilitate it. We need to consider this if we decide to recommend or even provide her with an anti-obesity medication. Orlistat would be safe, although as I mentioned earlier, it's rarely used due to side effects. Assuming she doesn't have any other contraindication, we could consider naltrexone bupropion. It's a great little drug that often gets ignored. Both medications contained in this drug have been around for a long time, but they've not been shown to be harmful to a developing fetus. The drug itself is contraindicated in pregnancy because weight loss is contraindicated in pregnancy. But if someone wants to become pregnant or becomes pregnant while taking the medication, I wouldn't panic. I would just stop the drug once they are pregnant. The combination of phentermine topiramate is off the table due to the topiramate, as topiramate has been shown to be associated with fetal clefts when exposure occurs early in pregnancy. Although we could definitely consider phentermine alone. It's not on here because it's only FDA approved for short-term use, but again, it's used for longer-term weight loss off-label a lot, and it could be a great tool here as the half-life is very, very short. I would not use a GLP-1 in this patient. The half-life of liraglutide is decently short, so it could be considered, but efficacy isn't great, especially given the expense. And the two newer incretins have a very long half-life, and we risk significant exposure should the patient conceive with them in her system. We will talk later about how tirzepatide decreases the efficacy of oral contraceptive pills upon initiation and dose increases. Not super relevant here because I wouldn't start this patient on the medication, but definitely relevant when discussing this medication in reproductive age women in general. Surgery isn't a terrible idea here, but only if Jenny is willing to delay pregnancy for at least a year. From what little we know going into the room, she wants to be pregnant now, but a discussion about delaying in order to address obesity treatment first could come up. We could lower the risks of pregnancy by reducing her obesity, although surgery isn't a panacea, and pregnancy after metabolic bariatric surgery also carries some risks. If she isn't in a hurry and she's willing to actively prevent pregnancy for some time, we could also revisit the previous anti-obesity medications that we took off the table. Assuming Jenny is ready now and her primary goal is pregnancy, we would put this option away for now. So, highlights for Jenny's case. 1. We should optimize treatment for PCOS. Consider adding metformin as we would even if she wasn't trying to conceive. I'm not going to make recommendations here about when to consider ovulation induction and which agent to use, as it's too far off subject for this talk, but it's definitely something to consider. I would discontinue her compounded medication that she's taking from her med spa, both because it's an unregulated medication, but also because, assuming it's reasonably similar to the regulated version, it likely has a very long half-life, and it should not be in her system should she conceive with or without our help. Getting Jenny referred to someone who can help her with an intensive behavioral intervention and prescriptive nutritional intervention would be fabulous, both to help with pre-pregnancy treatment of her excess weight and optimize her nutrition, and also so that she has someone to lean on to optimize these things during pregnancy, should it occur. If that person is able to manage anti-obesity medications, they would likely use one that can be discontinued upon conception, again, assuming she doesn't have other contraindications to one or more of those medications. So, what about managing the disease of obesity in a patient who is already pregnant? Let's go there next. Shauna. Shauna is a 29-year-old woman, gravida 3, para 2, who presents for a new OB visit. She has approximately 8 weeks gestation with a history of 2 previous term uncomplicated vaginal deliveries and has 2 healthy children. She reports greater than recommended weight gain with each of her prior pregnancies and states that she has not been able to lose most of the accumulated weight between the pregnancies. At the time of her initial visit, she expresses dismay and frustration with her weight, stating that she has recently gained a significant amount of weight and is already heavier than she was when she delivered her last child. She reports being 18 pounds heavier than she was 3 months ago, although she isn't sure how much of that weight was accumulated since conception and how much immediately prior to conception. Her body mass index today is 31.1. Although I'm sure we have all taken care of patients who lose weight during pregnancy for various reasons, current recommendations from pretty much every society and organization in the obstetrical space is that women should not lose weight while pregnant. They definitely shouldn't deliberately attempt to do so. Weight gain is expected and even encouraged during pregnancy. Now, we can certainly talk about managing gestational weight gain, and it is definitely warranted in Shauna's case. ACOG's recommendations about gestational weight gain are consistent with those of the Institute of Medicine. Because excessive gestational weight gain is associated with increased risks to both the mother and the baby, women carrying a singleton pregnancy with pre-pregnancy obesity should be counseled to limit their weight gain to a total of 11 to 20 pounds. In a perfect world, this is about 1 to 4 pounds in the first trimester and the remainder in the second and third trimesters at an ideal rate of about a half a pound per week. In the 2020 to 2025 ACOG prenatal care guidelines, weight gain and nutrition is addressed several times. Even if Shauna didn't bring it up herself, per ACOG guidelines, we should be offering anticipatory guidance for weight gain and helping Shauna develop a care plan. For this, as well as everything else, using shared decision making. ACOG even goes so far as to say that behavioral counseling to promote healthy weight gain and prevent excessive gestational weight gain has a moderate net benefit. Monitoring of maternal weight is a routine part of prenatal care, but ACOG also mentions that self monitoring can be recommended or performed alongside what is already being done during the routine prenatal visits. Despite her frustration with her weight and her recent weight gain, we have no reason to believe that Shauna wants to lose weight during her pregnancy. But if that were the case, we would have to have a more intense discussion. From what we know, which isn't robust but is consistent across all societies and recommendations, we should not encourage a patient to gain less than the recommended gestational weight gain. This is why all anti obesity medications, even those without any documented teratogenic risks, have instructions to discontinue immediately if pregnancy is recognized. I love that ACOG is talking about optimizing maternal health, with weight being a part of that. Beyond the Institute of Medicine's recommendations for gestational weight gain, ACOG recommends behavioral interventions focused on nutrition and movement. Before pregnancy is ideal, and again, consistent with obesity medicine guidelines, they state that even small weight reductions can have significant benefits. You likely already know this, but ACOG also recommends early screening for gestational diabetes in patients with obesity and one or more additional risk factors. These are physical inactivity, a family history of type 2 diabetes in a first degree relative, Black, Hispanic, Native American, Asian American, or Pacific Islander descent, a previous history of gestational diabetes, a history of macrosomia in a previous pregnancy, chronic hypertension, having a low HDL cholesterol or a high triglyceride level, having PCOS, or any condition associated with insulin resistance like prediabetes, current cardiovascular disease, HIV positivity, or an age greater than or equal to 35. If pre-pregnancy BMI is 35 to 39, so a grade 2 obesity, ACOG recommends weekly antenatal testing at 37 weeks. And in a woman whose pre-pregnancy BMI is equal to or greater than 40, so a woman with grade 3 obesity pre-pregnancy, they recommend antenatal testing beginning at 34 weeks. So, beyond normal prenatal care recommendations at this visit, what do we tell Shauna? It's not 100% straightforward, although what patient ever is, as we really don't know how much, if any, of the weight she has actually gained since becoming pregnant. Being conservative, because that's what we typically do when it comes to pregnancy, and based on what we just reviewed, we can safely counsel her that limiting weight gain to 1 pound for the rest of the first trimester is safe, and that she should limit her weight gain in the second and third trimester to a half of a pound per week. We can recommend nutritional and exercise interventions and make a referral to someone who can help her create these based on her own individual social and cultural preferences. If that isn't reasonable and she asks you what you would recommend as her only source of information, which, if your patients are anything like mine, is a possibility, you may have to come up with some guidelines for her. A good start would be eating a diet comprised of primarily whole foods, avoiding ultra processed foods, and definitely avoiding sugar sweetened beverages, while still getting sufficient protein and dietary fiber. We can tweak this based on how her weight is moving, adjusting recommendations if she is gaining too much weight or not getting enough. We can tell her that any movement is better than no movement, and for most people, the easiest and most acceptable way to increase movement is to encourage walking. If she has any of the additional risk factors we discussed, family history, ethnicity, comorbid conditions, etc., she needs an early screening test for gestational diabetes. Okay, we have one more last case presentation to go through. It likely won't shock you that this time we have a patient who is post pregnancy. Marcella is a 35-year-old woman who presents to your office for a well woman exam. She delivered a healthy baby boy via cesarean section approximately 9 months ago, and she wants to talk about another pregnancy. She weaned her son 3 months ago and just recently resumed menstruation. Since delivery, she has been preventing pregnancy using natural family planning and barrier contraception. She reports gaining 45 pounds during her first pregnancy, and since then has only been able to lose 10 of those pounds. Her body mass index at this visit is 34.2. She reports significant fatigue and overwhelm. Conversations like this can be tricky, especially when time is limited. In addition to addressing a future pregnancy, you also have to do all the things required during her well woman exam, after all. But we know that postpartum weight retention is associated with an increased risk of developing chronic disease, especially diabetes. This is even more pronounced in women who develop gestational diabetes, so it's definitely worth mentioning to Marcella. Now, we don't have a lot of great data looking at lifestyle interventions for obesity treatment in postpartum women. This isn't terribly surprising. Women's health in general is not studied very well. Lifestyle interventions are difficult to study, and this population is already struggling with so much that trying to get them to conform to study parameters and follow up is a disaster. Some of the studies we have show some results, but not surprising, the quality evidence is low. Consistent with what we know in obesity trials of all people, exercise only interventions are unsuccessful by themselves. Nutritional interventions are required to move the needle on weight. So, sending Marcella out the door with a recommendation to eat less and move more is definitely not the right thing to do here. Marcella isn't breastfeeding, so we don't have that to contend with, but even if she were, an intensive lifestyle intervention and a prescriptive nutritional intervention would be appropriate treatment. Just like we reviewed earlier, these are appropriate interventions before, during, and after pregnancy, although some modifications should be made depending upon the goal. If Marcella's goal is another pregnancy in the near future, we need to make sure we are optimizing for this and not setting her up for any micronutrient deficiencies. If we wanted to talk about anti-obesity pharmacology for Marcella, and she was breastfeeding, we would have to tell her that at this point we don't have much data on these medications and lactation, so they are best avoided. In women who are through lactating, which she is, we can address the appropriateness of each anti-obesity medication as we would anyone else who isn't pregnant, although with the knowledge that she's thinking about it again pretty soon. A lot of the management here is going to depend upon when Marcella is wanting to become pregnant again. She's 35. We know that fertility rates are slowly declining at this age and will worsen with time, more dramatically around 37 and even more so as she approaches 40. We don't know how long it took her to become pregnant with her first son, so we need to go there, and we also need to balance that with the risks of becoming pregnant at her current weight, already holding on to a significant amount of gestational weight from the first pregnancy. If she's a ways away from another pregnancy, let's say a year, focusing on her health and weight should be a primary concern. If she's willing to actively prevent pregnancy and use some type of reliable contraception, pretty much all of the anti-obesity medications are an option, and we will make that decision based on what we commonly refer to in obesity medicine as the 5 C's: criteria, contraindications, cues, combination therapy, and cost. We need to keep in mind that tirzepatide decreases the efficacy of oral contraceptive agents in the first month of use and for approximately 4 weeks following any dose increase. So if we are heading that direction, a non-oral type of contraception would be preferred for Marcella. She doesn't quite meet criteria for metabolic and bariatric surgery, but if she has any comorbidities, it may be worth referring her to a surgeon to discuss options there, as her body mass index is really close to qualifying her for that in the presence of comorbidities. If fertility is her primary concern and she wants to become pregnant sooner rather than later and doesn't want to actively prevent pregnancy, we are definitely more limited in terms of pharmacotherapy options, but we could definitely recommend something with a short half life or one that doesn't have teratogenic potential that can be safely discontinued if she does become pregnant. Knowing that she may become pregnant soon, we certainly don't want to set her up for dramatic weight loss that could cause rapid weight regain as soon as she conceives. This is the long game after all. Again, we're going to focus on these a bit more intensely since they are newer medications that patients are asking about and are getting from all sorts of clinicians in all sorts of roles. So you're likely to encounter them quite a bit right now. Specific things we need to think about when we have patients of reproductive potential on them. Tirzepatide, again, has been shown in studies to decrease the efficacy of contraceptive agents when starting and following any dose increase. For women using oral contraceptive pills, a second form of contraception is recommended during these windows. Semaglutide and liraglutide don't come with these warnings, although it may be because they weren't studied. With delayed gastric emptying being a prominent mechanism of action, it could be the case. Long-acting reversible contraception, contraceptive patches, and rings are not affected by these drugs at all. Although this class of medications has been around for some time, until recently they were used primarily for treatment of type 2 diabetes and not extensively in women of childbearing age because of the risk of fetal exposure in pregnancy. Semaglutide and tirzepatide both have very long half-lives, so unplanned pregnancies in women will cause exposure, even when they are discontinued immediately upon recognition of pregnancy. With so many women of childbearing age currently taking these medications, many with very little supervision, we will inevitably learn more with time. There are exposure registries, although women using non-FDA approved versions are less likely to be reported to registries, and it may be difficult to lump all exposure into one category, since these compounded drugs can be quite a bit different from the FDA ones. Only time will tell. So how do we counsel Marcella? In addition to doing her well woman exam, we need to counsel her about the relationship between aging and fertility, as well as the risks of beginning pregnancy at her current weight, and then use shared decision making to determine what her priority is. We can certainly refer her for a behavioral and nutritional intervention either way, and we can make recommendations about anti-obesity medications and contraception based on her ideal timeline for pregnancy. Like most of our patients, there is no one-size-fits-all answer, as we have to take a lot of things into consideration. I know we just skimmed the surface of the intersection of obesity treatment and women's health, but what I hope you take away from this talk is that 1, obesity is a chronic disease that has profound impacts on women of childbearing age. Early diagnosis and treatment is warranted. 2, managing obesity in women of childbearing age is nuanced and must be personalized based on reproductive goals. 3, obesity treatment is complex and is optimally delivered by someone with advanced training in the treatment of the disease and includes the use of lifestyle interventions, prescriptive nutritional interventions, anti-obesity pharmacotherapy, and surgical interventions. And 4, even if not providing targeted obesity treatment, women's health clinicians are well positioned to deliver targeted referrals and foundational knowledge and support to our patients. That concludes our discussion for today. I hope you found the activity informative in understanding treatment options for obesity management before, during, and after pregnancy. And I hope you now feel more confident about answering your patients' questions about weight management. Be sure to download the slides and the accompanying practice aids, and thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/SPP860.